I'm Eileen from GE Healthcare, your ASEAN CT and MR marketing leader. I'll also be your host for the next hour. I see some familiar names listening in to us today. I really appreciate you spending the time with us. And on behalf of the GE team, a very warm welcome and very glad to see you again. Today, we'll be discussing on how true AI-based deep learning image reconstruction impacts imaging in MR and CT. We are looking at, we'll be looking at how GE uses AI technology with deep learning to bring you sharper images with no trade-off. So this technology can be found in both CT and GE MR today. We're very happy to have our in-house clinical experts, Alberto from CT and Claire from MR, who will be sharing with you more on this topic today. So a kind reminder, feel free to post your question anytime throughout the presentation, and we'll take your questions at the end of the presentation proper. So we'd like to introduce our two keynote speakers today. Alberto. Alberto is actually joined GE Healthcare ASEAN last January, so it's almost a year. From Italy, he was the CT clinical leader from the from covering the Southern Europe region back then. And here he is with us today in covering ASEAN. After completing his degree from Pereira University in imaging, radiology, and radiation therapy, Alberto worked as a radiographer in several hospitals for 9 years before joining GE Healthcare in 2004 as a consultant, and eventually he is a full-time employee with us today. So over the course of the last 15 years, Alberto supported a lot of key opinion leaders, doctors, and generated a lot of clinical evidence from sites such as our dear friends at Central Cardiological Monzino in Milan. Alberto is also currently covering the role of CT application and clinical leader in ASEAN. So we're very happy to have him. The second speaker would be Claire. Claire started off as a radiographer in the Singapore General Hospital, specializing in MRI, and she has 5 years of clinical experience there. So following her passion in MRI, Claire advanced her journey as an MRI application specialist. And for the past 7 years, she has been training radiographers in Asia and ASEAN and South Asia. Claire is currently the lead MRI application specialist for the region of ASEAN at GE Healthcare, and she's here to share her invaluable knowledge and experience in MRI with us today. So without further ado, I'll hand over the time to our first speaker, Alberto, who will take on the topic. So Alberto, please.
Thank you, Eileen. I'm going to share my screen. Please let me know when you can see my screen and my presentation. Can you see my screen?
Yes.
Okay. Good afternoon to everybody and welcome to this webinar. An impactful CT image, a natural look CT image with no electronic filters perception, a CT image full of diagnostic information at the lowest radiation dose. Isn't what we look in everyday activity? My name is Alberto Mauro. I am a CT application specialist, and today I have the pleasure to introduce you the new GE image reconstruction technology called Fidelity. For a long time, all of us heard about artificial intelligence, machine learning, and deep learning as main helpers in management of complex processes with better and sometimes amazing results. Deep learning is part of artificial intelligence. It's used for data processing and based on neural and learning networks. It represents the way to reproduce human intelligent behavior from existing data to accomplish a specific task in a faster and better way. For what purpose do we use the deep learning technology? Since the beginning, CT images have been reconstructed with filtered back projection with very good results for radiologists and patients in terms of image quality. This process is based on a direct proportionality between radiation dose and image quality. The higher is the dose, the better are the images. Over the years, the increased request of CT exams created a big warning for biological damages linked to X-ray exposure and consequently systems to lower the dose, maintaining good image quality were introduced on the market. Thanks to iterative and model-based reconstruction algorithms, the dose levels decreased, but the natural image look was modified. Deep learning technology allows us to re-obtain the FBP image look, maintaining the dose decreases of iterative recon technologies. The deep learning development is composed by three different processes: designing, training, and verifying. First phase is to design a neural network, that means define tools able to recon CT images based on 40 years of GE knowledge. Second phase is the learning, that means teaching the system to recon the best possible images. To obtain this, the high dose and quality FBP images were used because are pure. So it's mandatory to take advantage of them to achieve the best result. Third phase is verifying. Deep learning algorithm compares the low dose acquired images with the high dose and high quality ones and adjusts the recon parameters till when the images are the same. In this way, the users will obtain high quality images with low radiation dose. ASIR was the first iterative recon algorithm introduced and today is the most used in terms of number of exams. ASIR-V is the most recent one with more mathematical models to decrease further the dose, maintaining the image quality. True Fidelity increases in an exceptional way the parameters at stake to obtain a reconstruction with an image quality close to perfection. The main differences are in the exceptional increase of the evaluated parameters and in the validation based on a vast number of data sets. In addition, the reconstruction time is very fast because the training and the parameters optimization were done in GE Research Center, while on site, all these processes are directly applied. Why is a True Fidelity a groundbreaking? Iterative recon algorithms represent a trade-off between dose and image texture, while True Fidelity can obtain the natural image look with no impact on the low dose currently achieved. In the picture, we have a big cow liver with ribs around, so we can mimic body to show the plastic appearance, and the liver is the most challenging organ in the body for CT imaging. This is MBIR with plastic appearance. This is True Fidelity. This is what we need with a perfect noise texture. No blotchy, no plastic, but a very clear, very sharp image. This is an image that looks like a filtered back projection, but it's heavy noise reduction. Why this? The technical answer is in the noise power spectra that you can find in True Fidelity white paper. When you remove noise from a CT image with model-based iterative recon, you remove the high frequency noise. So the total noise in the area below these curves, but when you add MBIR, you remove high frequency noise. And what you have left is the low frequency noise. And the low frequency noise is the cause you have this kind of plastic image. With true fidelity, we have the same noise appearance that we have in filter back projection. So we will have these very pleasant images. We removed noise in all different frequencies and not only in the high frequencies. It's nice to use these testimonials. As you can see, excellent contrast to noise ratio, lesion delineation with improved texture and no plastic appearance in the image. In this graphic, you can see the noise reduction linked to different image recon algorithms. Consider an FBP as the baseline, MBIR and true fidelity bring to a noise reduction with a consequent improvement in image quality. I ask you to pay attention to the red column. It represents the mean amount of iterative level used by radiologists because a higher value may affect the image texture. The gray column represents the maximum usage of the new deep learning algorithm. That means that there is not an image texture variation. The green column represents the possible optimization of scan protocols with true fidelity to achieve image quality improvements and radiation dose reduction. What affirmed in the previous slide is easily demonstrated in this clinical case. We have a coronal MPR at 0.625 millimeters slice thickness for a BMI 49 patient. In filter back projection, diffuse noise complicates the similar densities tissue and edges identification. The image in the middle is obtained with A0V at 50%, which represents the main used value. We can appreciate a good noise removal. True fidelity image deletes almost the whole noise without impacting on contrast and edges detectability. If the quality of this type of recon is so high at the same radiation dose, we can ask a new question. Can true fidelity optimize the dose too? Let's try to answer to this question with a pediatric brain case study. As in BMI 49 patient, the images were reckoned in filter back projection, AZRV 50%, and true fidelity. The measured noise as a standard deviation is 9 in FBP, 6 in AZRV, and 3 in true fidelity. Till today, the AZRV image is the one used to report the case. I could try to reduce the dose to obtain the same noise with true fidelity. Please note that the DLP is 330, that means a low dose yet. This is an impressive ultra low dose chest acquisition at only 0.11 millisievert. With hyperdrive, 0.28 rotation time and 1.5 pitch, the acquisition time is less than 1 second to avoid breathing artifacts also in patients who are not able to have a good apnea. This question makes us understand that a lot of sites are yet very careful in dose reduction, so they can focus on image quality improvement. True fidelity achieves very good image quality for an improved low contrast resolution and less noise. This case allows to appreciate the very high noise reduction level and the homogeneity maintenance for similar tissues like the fluid in the stomach and the big hepatic lesion. We appreciated noise reduction, but what happens with high resolution? In this lung fibrosis case study, we can compare the A13 slice lung parenchyma evaluation with the obtained in true fidelity. Please look at the definition of the images. Here we have reduced noise index and no bone kernel is needed. Edge filter is used. So we have an edge attenuation improvement. And thin slices are without any noise. And what about the use of low KV? Deep learning algorithm and low KV lead to different benefits. Increase the contrast to noise ratio. Reduce radiation dose and reduce iodine dose. We can promote low KV scanning. With low KV, we have a better contrast but blurry edges of the low contrast objects. With true fidelity, of course, we have better contrast, but we don't suffer from noise texture at the low contrast objects. We can claim that with this new technology, we can actually implement low KV scanning with no limitations. In this 0.625 image low contrast, objects are very sharp. Low contrast detail are very smooth and accurate. It is a powerful message to combine things. $80 kV for a routine exam is now possible. As you can see, radiation dose is very low. CTDI vol is 2.67 milligray. And there is no loss in diagnostic information. This case helps us to understand better. The exam shows a 57% dose reduction due to 100 kV acquisition, while CNR and SNR are higher with true fidelity. The image quality is not maintained, but is improved. If we want to obtain more clinical information from CT images and storage is not an issue, can we go further? After this sentence, can we modify our workflow in order to improve diagnostic confidence? It's evident in this image comparison that true fidelity thin sections free from noise, but with high intrinsic spatial resolution are better. But what is the price to pay for all these improvements in terms of recon time? Time is crucial, especially in emergency patient management. True fidelity is extremely fast. It can be used in trauma and in very powerful way, as you can see regarding the data of Recon. In 2020, GE introduces the first deep learning image reconstruction from gemstone spectral imaging, GSI. Another industry first with a bold vision to transform the image quality for dual energy spectral CT with true fidelity for GSI images. Outstanding detail, clarity, texture, dose without compromise. The data produced with fast KVP switching is reconstructed with deep learning algorithm with no limitations to all GSI image types. All the benefits of true fidelity are imported to GSI image types in order to have the quality that our customer expect, especially with low doses. Monochromatic images are fundamental, especially at lower KAV levels, because the contrast is higher, so it's easier to detect and evaluate the lesions. This impacted on image quality since the noise was higher when lowering KAV. Now, with True Fidelity, the issue is completely solved, and the images are more natural. Iodine images represent the effective impact of iodine uptake, and this often helps the clinician in better finding and evaluating the lesions. At low doses and with high BMI patients, noise impacted negatively on the image quality. With GSI True Fidelity, the texture is highly improved. This means that boundaries and structures of lesions are better depicted. Virtual enhance are important first to decrease radiation dose, avoiding conventional non-contrast acquisition. Then, because you can depict materials like calcium, fat, and blood, when the true unenhanced images are not available. True Fidelity for GSI Virtual Enhance reduce noise with optimal texture, even at thin slice thickness, pushing the customer to skip the conventional non-contrast acquisitions. Metal artifact reduction in dual energy CT acquisition are minimized using MAR. Now, with True Fidelity, you can add to all GSI MAR images the best image quality to have images free from artifacts and noise. The computational power of Extreme Recon server allows to our customers to have a fast speed image recon in routine and in acute care settings. No limits to the best image quality for a better and faster diagnosis. The accessibility of dual energy can be limited by the patient size, since 80 kVp is a core requirement and ultimately determines the quality of the resulting images. Dual energy techniques provide the inherent diagnostic benefits such as lesion detection, depiction, characterization, and artifact reduction in many key clinical areas. These extraordinary benefits should not be limited to some patients, but are available to all patients. The sentences of our key opinion leaders are the best endorsements for GSI capabilities, as you can see. Professor Foley from further Milwaukee pushes on the importance of True Fidelity in GSI because now it can use 0.625 millimeter images, best spatial resolution, and 40 kAV images, best contrast resolution, with no degradation in image quality. Dr. Gupta from Houston Methodist now can use for primary read 40 kAV images for a better lesion depiction, since True Fidelity decreased dramatically the noise at low kAV. Dr. Legoux from CCN Paris tells us how he's improved the image quality even with low kAV, so we can match the gain we have in contrast enhancement with noise-free images. In pulmonary embolism detection, the fast acquisition with hyperdrive minimizes the need of breath hold, while iodine images can help to identify pulmonary embolism-associated perfusion defects. Iodine map segmentation performed with our software GSI pulmonary perfusion in thoracic VCAR, available on AW and the AW server. Post-EVAR endograft leakage with KEV decreasing. The noise we were used with low KEV now is part of the past with true fidelity. GSI in emergency. The power to detect bowel ischemia with the help of virtual unenhanced images showing wall hemorrhage. GSI-MAR can be applied to all GSI image types, reducing metal artifacts which hidden the anatomy and pathology. And in this case, you can see an amazing metal artifact reduction in a very critical area like the pelvis. Here we have an excellent image quality with GSI Mars and true fidelity. Please look at the subtotal metal artifact removal on true fidelity compared with easier. High BMI and metal implant. GSI Mars and true fidelity together show us a very nice image free from artifacts and noise. The known image quality issues for obese and morbidly obese patients are now dramatically minimized with true fidelity. Professor Foley remarks the GSI capabilities in better detecting and evaluating the pancreatic adenocarcinoma, plus the added value of true fidelity in avoiding the image degradation in a 46 BMI patient compared with conventional technologies. High BMI patient, but excellent image quality. We are approaching the end of this presentation, and it's time for the last and maybe most important question. Can we trust it? This is a fair question, and we can answer it easily and visually. We can subtract from the full detailed FBP image the denoise iterated images and evaluate the results. In the first example, on the left, when the first generation of iterative algorithms, we can still identify in the subtracted image an anatomical profile. On image in the middle with model-based iterative recon, the improvement is evident, but we still can see the external profile and some internal details. On the image on the right, I invite you to look carefully at the subtraction. It is just noise. We only reduced noise. No structure is removed from the regular image. Everything behind the noise is preserved. You don't miss any clinical information. The image profile is the proof of a true fidelity compared to the natural and well-known appearance of an FBP image. We can summarize our journey with following take-home messages. True fidelity consistently decreased image noise compared to the previous iterative recon algorithms, adding a great capability to further decrease. True fidelity maintains a natural image look compared with the previous iterative recon algorithms, making easier the image evaluation. True fidelity allows the use of thin slices to improve diagnostic confidence. True fidelity allows the use of low KV to improve contrast detectability and lower radiation dose. True fidelity doesn't impact high pitch and low rotation time, super fast acquisitions. True Fidelity benefits all GSI image types, plus is accessible to all patients and especially obese. So we can really trust in True Fidelity because all the FBP anatomic details are maintained. On GE Healthcare website, you can find customers' testimonials supporting what said till now, and the literature is growing continuously. Thank you very much. I now have pleasure in handing you over to Claire.
Thank you, Alberto. Just let me share my screen. All right, is everyone seeing my screen?
Yes.
Okay, great. Okay, thank you very much, Alberto. A very good afternoon, everyone. My name is Claire, and I am the MRI application specialist based in Singapore. So continuing from what Alberto has shared, I am now going to talk about how true AI-based deep learning reconstruction impacts clinical MR imaging. Let's first start off with a short video clip. So I'll carry on with my presentation. So isn't Air Recon DL a dream of all MRI radiographers? So we no longer need to worry about the trade-offs between image quality and resolution and also scan time. Air Recon DL is a pioneering deep learning-based MR reconstruction technique that will change the way you think about MR imaging. As you have seen earlier, it challenges the historical balancing act between image resolution, SNR, and scan time. It is designed to increase productivity by enabling shorter scan times, improve image quality at the foundational level by removing image noise and ringing from the raw data. It also delivers a sharper and clearer through Fidelity MR images and enables users to set preferred level of SNR improvement. So this is an example of an image with and without Air Recon DL. For this webinar, we will be looking at these 4 main points: how Air Recon DL addresses today's problems, how it works, what are the clinical benefits of Air Recon DL, and also what are some of the feedback from our early adopters. So, what are some problems that we face today? Intense pressure to increase productivity without impacting image quality. Long exam times, repeat scans, and unpredictable patient scheduling. And also MR images that are grainy and has low diagnostic confidence. I'm sure all this sounds familiar to all of you. And these are just some of the problems MRI departments have been facing every day. And why Air Recon DL is needed. Over the years, the number of MR procedures have been increasing, making the demand for MR slots very high. Studies have also shown that 20% of all MRI exams require repeated sequence, and one of the contributing factors is poor image quality. With repeat scans, exam times have been increased. So, most importantly, Air Recon DL is a solution to better balance SNR, scan time, and resolution. So what does Air Recon DL delivers? It increases productivity. With shorter exam times, patient throughput is increased. And with this, it may also lead to more predictable scheduling for the department. Based on a user survey involving 21 radiologists, they are able to read images easier and faster with Air Recon DL. And the tolerance of protocol and patient variations is also higher with Air Recon DL. And most importantly, the images appear directly on the MR console without any delay in construction time. So, Air Recon DL, how does it work? All of us are mostly familiar with the conventional MR image reconstruction, whereby the raw data, which is also what we commonly term as case space, will go through a raw data filtering to compensate for the Gibbs ringing artifacts and noise. After which, the filtered case space will go through a Fourier transform to form the MR image, which will be passed through a set of image filters such as sharpening and smoothing before the final conventional image is produced. And this is how this is how images are reconstructed on most of the MRI machines today. Let's have a closer look at the images before and after image filters. The image filters ultimately compromise the spatial resolution of the final image and offer moderate denoising, and the noise can still be seen at the background. And these processing tasks are not 100% efficient. As you can see, there were still some lines and Gibbs artifacts remaining in the final conventional Recon image. Air Recon DL utilizes a totally different image reconstruction method as compared to conventional reconstruction. It uses neither raw data filters nor image filters. It uses a deep neural network to reconstruct MR images with intelligent ringing suppression, user-selectable SNR improvement, and produce image with sharpness and high resolution. In this new DL Recon algorithm, deep learning is an integral stage in the reconstruction pipeline and aims to replace the weakest portion of the conventional reconstruction, which is the raw data filters and the image filters we have seen earlier. This is a phantom test on resolution and image sharpness. A phantom of multiple dots of different sizes was used for the scan of these two images. The one on the left is done with conventional image reconstruction, and the one on the right is an Air Recon DL image. From these two images, you should already be able to see that the image on the right is much sharper. When we zoom in to have a closer look you can see that the conventional Recon, there is a ring around each of the dots. Okay, this is the Gibbs ringing artifact that we have been talking about. So, and there is also loss in fine details, as you can see from the small dots here, that they are not as well resolved. Okay, there's fine details lost on the conventional reconstruction. With the DL Recon, you can see that the ringing artifact has been suppressed and the structures appear to be sharper. Deep learning-based image reconstruction provides highly resolved images with no truncation artifact and a tunable noise reduction factor. The final DL Recon image with no Gibbs artifacts and unnoticeable noise really speaks for itself in comparison to the conventional MR reconstruction. As you can see from the green arrow, the lesion is much more conspicuous on the right with better contrast to noise ratio. So we've seen how Recon DL works. Next, let's look at what are the clinical benefits that Recon DL can bring us. First of all, it delivers higher SNR. The two images here are with the same scan time, same voxel size, and same raw data. Only difference is that the right image is reconstructed with Recon DL. As you can see, with DL Recon, the noise in the image, both in the background and also the myocardium, are greatly reduced. The myocardium is a lot cleaner, with no loss in details, and is much easier to read. This shows that DL Recon gives us increase in SNR without any compromise in image quality. This is an example of tibial nerve imaging. In today's nerve imaging scan, we typically use very thin slices and high resolution, which results in poor SNR unless we use higher necks or higher averaging. So this is a 4-minute scan with 2 necks using conventional Recon. But of course, the more practical acquisition in clinical setting is to get a scan time that is lower. And here is a 256 by 180 and with a scan time of 1 minute and 10 seconds. Now, it's certainly a faster scan, but do we see the structure in the tibial nerve? Not really. We are not able to see the bundles that we see as on the higher resolution image. So we use the same set of raw data and put through with Recon DL. And the result of the image is excellent, whereby we are able to see the same detail that we see with the higher resolution scan that was done with a higher scan time. So this is a proof that Recon DL provides image that has true information without any loss or any makeup data with the resultant Recon DL image. In this ankle example, we see how Recon DL can deliver higher resolution with shorter scan time. On the left is a conventional 352 by 256 image at close to 2 minutes, which is not a bad image. On the right, it is an Recon DL with higher matrix and a shorter scan time of only 1 minute and 18 seconds with a high resolution of 640 by 384. Right, so the resultant image shows sharper trabecular markings and structures with higher resolution. I think from here you can see which one will be the preferred image for the radiologist. This is a great example of combining scan time reduction with higher matrix acquisition, and we are able to get the best of both worlds with Recon DL. As we know with MRI physics, CSF is a high-intensity structure, and we often see a lot of Gibbs ringing artifacts around CSF. With intelligent ringing suppression, which is a benefit of DR Recon, we are able to reduce the Gibbs ringing artifacts from the image. This does not only work in the brain, but also other anatomies like spine that are prone to similar Gibbs artifacts. The level of Recon DL strength is adjustable in 3 different levels: low, medium, and high. The difference between the 3 levels are the factor of noise removal. Low has a slight noise removal factor, Medium has slightly higher noise removal factor, as you can see from the image here, and high has the highest noise removal factor, as you can see. But all three levels has the same intelligent ringing suppression, whereby it removes the truncation artifact. With this user-selectable strength, the users and the radiologists are able to choose based on their image preference. Recon DL also works for all anatomies. This is the different level of DL Recon strength for body scans. Recon DL is also compatible with the use of all coils. This is an abdominal imaging done with GE's award-winning Air AA coils. The image on the left is from conventional reconstruction, and on the right is Air Recon. And you can see that with the Air Recon DL, the image looks absolutely different with very good SNR and shows finest details that conventional Recon cannot achieve. Even with a large FOV, a large coverage of the entire abdominal area, we were able to achieve highly resolved images with Air Recon DL. So as we know, Air Recon DL is something really new and still evolving. Air Recon DL for diffusion is the newest addition. It's compatible with single shot DWI, as you can see from this brain DWI image here. With Air Recon DL, we are able to achieve B1000 with high resolution of 2 mm at a scan time of only 20 seconds. It's also compatible with focused DWI for reduced phase FOV diffusion imaging. You can see that Air Recon DL, the signal is better and the images are a lot sharper as compared to the conventional, though the resolution is the same. And this cervical DWI shows overall better SNR as compared to conventional Recon. This is a graph showing the relationship between SNR and voxel volume. SNR is directly dependent on voxel volume, whereby the larger the signal-bearing voxel volume, the greater the SNR will be. The SNR of both conventional and Air Recon DL varies linearly with voxel volume. However, with the noise removal function of Air Recon DL, it has a steeper graph, which means smaller voxel volume have higher SNR as compared to conventional reconstruction. The vertical and horizontal dotted lines here, they represent the clinically acceptable spatial resolution and SNR threshold. For SNR, the higher the SNR, the better. And for voxel volume, the smaller the voxel, the better. As you can see here, the clinically acceptable voxel volume for Air Recon DL is higher. This is because DL Recon has image sharpening benefit of intelligent ringing suppression, which makes image of larger voxel volume appear to have higher resolution than conventional image. Now, consider point A over here, which is this image. Okay, though the image has got sufficient SNR, whereby the SNR is above the clinical threshold, the image resolution is not sufficient. It's not clinically acceptable. It is actually bigger than the acceptable threshold for voxel volume. With Air Recon DL, we can use the same SNR, but at a lower voxel volume, which is over here. Meaning, scanning at the same SNR, okay, we are able to achieve a much higher resolution with Air Recon DL. In a different scenario, if we were to start with a point C scanning with an acceptable voxel volume with conventional reconstruction, the image will have sufficient spatial resolution but insufficient SNR. Air Recon DL can be used to improve the SNR to acceptable levels, which brings us back to point B here. With the clinical acceptance threshold, there is a very narrow range of voxel volume with conventional reconstruction that will meet both the SNR and the spatial resolution threshold, as indicated by the red arrow here. So this is the only range for conventional reconstruction that is clinically acceptable. With Recon DL, there is a much wider range of voxel volume indicated by this blue arrow here, signifying the freedom of and flexibility with imaging protocol with Recon DL. And this graph shows the relationship between SNR and scan time. The SNR of both conventional and Recon DL varies as the square root of scan time, which explains the shape of the graph here. Similar to the previous graph, we have the dotted lines representing the clinical acceptable SNR and the resolution, which is the SNR and the scan time. Okay, so point A represents an unacceptable scan time with sufficient SNR. With Recon DL, we can achieve a shorter scan time at a similar or at the same SNR, preserving the SNR. And this will be the image that we will get with Recon DL, but as compared to image A here. On the other hand, looking at point C, it has acceptable scan time but insufficient SNR. The image looks too noisy. Recon DL can improve the SNR while keeping the scan time constant. The acceptable scan time range for conventional reconstruction is very small, as indicated by the red arrows, and Recon DL has a larger range of acceptable scan time, as indicated by the blue arrows, as compared to the conventional reconstruction. So with Recon DL, we are able to reduce scan time while maintaining sufficient clinical SNR. So we have been looking at SNR and versus scan time and SNR versus voxel volume separately. Now let's look at a more complete picture of the protocol space and consider SNR, voxel volume, and scan time all together. The acceptable clinical protocols that are those that simultaneously meet the 3 points, the 3 criteria, which is the scan time, voxel volume, and SNR. This red graph here represents the clinical SNR acceptable for conventional reconstruction. Anything that falls under the graph, okay, is unacceptable SNR. Okay, that falls above is the clinically acceptable SNR. And this is the clinical scan time threshold. And this vertical dotted line is the clinical resolution threshold. And the only acceptable range of protocols for conventional reconstruction falls within this little red triangle here, right? So this is the amount of protocol space that we have, we are able to play around with conventional reconstruction. Let's have a look at how clinical protocol space for Recon DL looks. With Recon DL, the clinical SNR threshold graph has shifted and increased the space for clinical acceptable SNR. The acceptable range of protocol space has been expanded to a bigger triangle as seen here, and the users will have the option to decide whether they would like to have more resolution, faster speed, or higher SNR. For even more focus on scan time reduction, we have carefully developed Recon DL hyperspeed imaging protocol, and the scan time is tremendously reduced. Take, for example, this routine lumbar spine study with a total scan exam time of only 250 seconds, which is below 5 minutes for the entire lumbar spine scan. Recon DL is transforming the way we think about MR. Gone are the days of scanning lumbar spine for 20 minutes. Recon DL hyperspeed protocols will be a great alternative for uncooperative patients or even claustrophobic patients. If the focus is on resolution, Recon DL can be used to push for very high resolution 2D imaging. As seen here in this example of the tongue with 1.2 mm slice thickness, the wrist is scanned with 1 mm slice thickness for a 2D imaging, and this is a foot example of a foot at 1.6 mm. You will also be able to obtain a near isotropic acquisition, which allows you to perform multiplanar reformats from 2D imaging, okay, which was only possible with 3D acquisition in the past. Look at this example here of the shoulder. Note that this is not a 3D cube sequence. It is a 2D PD flatset that is almost isotropic at 0.6 by 0.6 by 0.7 resolution, and it gives us the multiplanar reformats. Acquisition at such high resolution is almost impossible without Recon DL, as you can see from this conventional image here. Recon DL has now been installed at several GEMR sites across the globe, and we are excited to see how these customers are using it to address their specific needs. And the most compelling utilization of Recon DL is to reduce imaging scan time. This table shows the percentage of scan time reduction from different customers, both university hospitals and also outpatient imaging center. Across a wide range of anatomies, we are seeing routine examination times reduced between 30 to 50% with images that are all with higher SNR and better image quality. This scan time savings can naturally translate to more clinical efficiency, such as added time for cleaning and disinfection between patients, and more patients can be scanned in a day. And these are some of the feedbacks that we have gotten from our early adopters, which you can have a look. A feedback from Dr. Pascal from Paris. He said that I have the best of both worlds. I do not have to choose between improving the quality of the exam and shortening exam time. So, which is a good improve in image quality at a shorter scan time. And from one of our early adopters, Dr. Pashut from Shields Healthcare Group using Signa Pioneer 3T. His comment was, it was surprising to me how easy it was to get great looking pictures and how fast we were able to go. This is a comparison of his original prostate protocol versus the optimized Recon DL prostate protocol. And the overall scan time for the 3-plane T2 small FOV has a reduction in almost 30% in scan time. And Dr. Randall from Houston Medical Imaging also shared his initial protocol experience. The scan time for the routine protocols such as brain, prostate, pituitary, hip, and wrist with Recon DL are on average reduced by 50% or more. And the image quality were not sacrificed. In fact, the image quality was better with better SNR and higher resolution. With this, I would like to thank you all for your attention, and I'm going to hand the time back over to Eileen.
Thank you, Claire. Thank you, Alberto. Just on time. We hit the top of the hour. So all the speakers are active right now. We are ready to take any of your questions. Thank you so much for listening in to the versions of how we interpret deep learning in CT and how you see the same technology being applied in the world of MR. So while we give the participant a few minutes to type in your questions. Don't worry, your questions would stay anonymous. Just feel free to type in your questions on the Q&A chat box over here. And the speakers are ready to take your questions anytime. So while we give the attendees some time to ponder and digest whatever that is presented, just wanted to also hear for Alberto. I think you have first-hand experience with True Fidelity and seeing it actually implemented in the customer site. So what are your can you share with us what was the customer's experience? What was it like? What was the feedback? And what was your take when you supported this customer?
Thank you, Eileen. Yes, we started this experience exactly 1 year ago here in Singapore, and I will tell you that.
Sorry, Alberto. Nice. Can you increase your volume? You're a little soft.
Yes. We started exactly 1 year ago here in Singapore with the first experience of True Fidelity in ASEAN, and it was very nice since the beginning. The appreciation that we received from the customer. So customer feedback was amazing because they really improve image quality, and of course they started to reduce the dose. So now True Fidelity is implemented on all body areas, especially in oncology and also in cardiac. And so we are very happy of this impact. That again is reflected on all our other customers here in ASEAN, in Thailand, or in Malaysia, or in Philippines. All the feedbacks are very good. Customer really appreciate this breakthrough.
That's good to hear. I think when such new technologies are up on the market, it can be quite daunting or can be quite overwhelming to say what's real, what's not. You know, Claire and Alberto, can you share some experience on how is there any things for the users, for radiographer, radiologists to take note of when they're using this tool? How do they what would give them that confidence to say that, hey, you know, this AI tool is not taking out things that they are not supposed to? So maybe we can go with Alberto for CT, and then we'll move on to hear some insights from Claire for MR.
Okay, for CT, we have 3 levels of True Fidelity: low, medium, and high. So what we do initially is to submit to our customers the 3 different levels of reconstruction. At the end, we arrive at one solution that is the common for all the users, and then we embedded it in the protocol. So the images come out directly from the protocol. Then, if they want to change it, or if they want to increase the resolution or decrease the resolution, they can recon with other kind of a level.
Sorry, I was on mute. What about MR, Claire?
Yeah, so similar to CT, for MR, we also have 3 levels, okay, which is the low, medium, and high for Air Recon DL. And the most important part with MR Air Recon DL is that it's not a filter. It basically works on the raw data at the image construction level, right? It's unlike any other imaging filters whereby you apply it after the reconstruction. For Air Recon DL, it's done at the reconstruction level. Okay, and we have also a lot of case studies whereby it shows that it doesn't we don't miss out on any pathologies or any information. Only the noise is being removed, and no anatomical details are lost throughout the whole process of this reconstruction. And the recommendation from us is really to go with a high level of Air Recon DL, because we've seen many of our customers who have started using Recon DL, they absolutely love the high Recon DL images.
Okay. Thanks for the tips. Oh, we have a question. So, so this attendee is asking, based on the customer experience using Recon DL. So I think this question will be for MR specifically. What trade-off do they prefer? Scan time or higher resolution, or does it depend on any indication? So that's part one of the question. I think there's part 2 and 3 of the question is, how fast or how low do they go in terms of scan time or voxel sizes? And then the third part is, any plans for the 1.5T system to be equipped with deep learning as well? I think there are a few fundamental good questions here. So maybe we'll focus on we'll go part by part first. First, any trade-off do customers prefer when they're using Recon DL? Scan time, higher resolution, or it depends on other things? And then how fast or how high do they go in terms of scan time and voxel?
All right. I think that's a great question. So which one do you want to sacrifice, right? So from what I see is most of the customers, they go for definitely they'll push for faster scan time. Okay, that's the first thing they go for, right? Because throughput is obviously the most important thing. And also you can get actually, in fact, both. If you have seen the images I have shared earlier, okay, you not only have to choose one benefit. You can actually go for faster scan time. At the same time, you get higher resolution. So that is definitely possible. So I would say there's no trade-off as I've seen so far. Okay, so if let's say if the first thing when customers, the first adoption would be, we will increase the resolution and go for shorter scan time. All right.
So I think the fundamental exactly, thank you, Claire. And if I can add on, I think the fundamental thing here is why DL Recon or deep learning reconstruction, whether is it in CT or MR, is so transformational in this time when it launched, is because it's different from the conventional iterative recon that you have been seeing all this while, you know, where you are forced to choose between a trade-off, right? So that's why when GE launched our Recon DL for MR and True Fidelity for CT, there is absolutely no trade-off. You can get both the benefit. If you want reduce scan time and increase your image sharpness in terms of voxel size or resolution, you can push both. So that's why we keep saying that this is the dream. This is, you know, we're making the impossible possible for you today with artificial intelligence-based reconstruction. And that's how we are different from all the competitors out there who are still using the old technique, and then they push it, you know, and they claim some deep learning just because it's algorithm based, but it's not the same. Because once you really go in deep dive, there is some trade-off for them. So Claire, there is the mini third part of the question here. Any plans for the 1.5T system to be equipped with deep learning?
Definitely. So it hasn't gotten the C marked, okay, for 1.5T, but we have already gotten the FDA approval, okay, for 1.5T. So very soon, we'll probably be able to see Recon DL in ASEAN region. So
yes,
we'll be very excited to try out on 1.5T, definitely.
Yes, that's right. So right now, the treaty is available for you know, for any commercial interest to be executed in ASEAN. And then the 1.5T will be coming really soon. So definitely within this year. And it would be for across of all our fleets. Okay, we have another question. So this question is also for MR, but we'll also pull in CT as well on this later. So the question is, can Air Recon DL detect tumor?
Yeah, so Air Recon DL basically works on all image contrast like T2, T1, so any 2D FSE sequences that we have been using for oncology detection, like for tumor detection, Air Recon DL is applicable. So definitely it plays a part with detect. I wouldn't say it helps to detect tumor, but it helps with the scanning for any request for tumor detection. If that answers the question. Yeah, so it actually helps. I mean, when a patient comes for patients are very ill when they come in for scans, right? Especially if, let's say, we're talking about oncology patients. So Air Recon DL actually helps to make their whole experience of scanning faster, because it reduces the scan time, reduce the amount of table time they need to spend in the MRI machine. And also with a higher resolution, you can actually detect even small lesions.
What about CT? I think the same over here, but of course, in the CT world, our deep learning based image reconstruction is called True Fidelity. So, Alberto, you know, CT is usually, you know, the first line when people wants to even find out whether that the lesions that they see, the masses is screening is almost the first line for with CT, right? So what about, can True Fidelity in CT detect tumor?
Yes, we can see that two things. In a conventional CT, lowering the KV, we increase contrast to noise ratio, so it's easier to detect. As we saw also, and better with the spectral imaging with GSI, iodine maps and low KV can help a lot in tumor detection, depiction, and visualization. So with True Fidelity now, we add to this power the very, very clean and sharp image, so the diagnosis will be easier for sure.
Okay. Yeah, I think, Alberto, thank you for bringing up this really good point. So right now, we don't only just introduce our deep learning based image reconstruction True Fidelity. We are always constantly expanding the indication, right? So thank you, Alberto, for sharing with us that now True Fidelity has expanded to being used with the GSI, which is gemstone spectral imaging, for those who are unfamiliar with acronyms. So right now you can use when you're doing GSI images, you can apply True Fidelity to further enhance the type of image quality or even the scan time when you do that. So great stuff. And absolutely, I think spectral imaging would we really see a lot of benefit with using spectral imaging in oncology. So we are hoping that the same goes to yeah. Okay, I think we are up just nice. We've hit the 15 minutes for our Q&A session. So if there's no further questions, or if you have further questions, feel free to type in, and then we will, if we don't have time to attend to this question, we'll, consolidate in an email, follow-up email, and respond to you accordingly. So I'll close the Q&A session. And then I just wanted to share that thank you so much for staying the session with us. We are definitely hoping to see you tomorrow, where we will also be tackling a topic that is very close to heart. We're tackling literally close to heart because it's going to be on cardiac. So we're looking at CT and MR cardiac imaging, and we're going to look at a variety of challenging cases that can be addressed with the latest technology, and how we're going to do that with artificial intelligence. So I'll leave you as that, and do visit our innovation.gehealthcare.com site, where we will be sharing with you all the latest information, the products, features that we have launched in just last RSNA, which was 2 to 3 months ago. And you will find a lot of educational mini clips, 5 minutes, 10 minutes mini clips that is very easily digestible. So it will be innovation.gehealthcare.com, and then you can see a lot of our information, a lot of modality updates over there as well. Okay, thank you so much for the time. And thank you so much, Claire and Alberto, for taking your time for this lunchtime session.
Thank you.
Thank you.
The session. Thank you so much.